Our main talk today is we have a member of our own community, well known to many of us. He's just a super important part of the Houston Oasis community, and his day job, he is a physician, and he's got a compelling title today. Heroin is a brand name, and we're going to find out what that's all about right now. Let's welcome our friend Richard Andrews.
Thank you for letting me chat here. Heroin is a brand name. It actually is a brand name. First, I want to talk a little bit. I want you to bear this.
Hang on a second, Richard.
Oh.
Can't hear that well.
Paracelsus was a Swiss-German physician from the 1800s, and he came up with a quote which is, "The dose is the poison," which seems kind of like an obscure quote or comment, but it has to do with the idea that really it has more to do with the dose of something, what the effect is going to be frequently, than the substance itself. Obviously, the substance itself also plays a role, but that's an important thing to bear in mind when talking about drugs and the effect of drugs on drug policy. He was the so-called father of toxicology. Toxicology is the science of studying adverse consequences of substances in the body. Heroin, of course, can be deadly. It kills people all the time, mostly from respiratory depression. It represses the breathing mechanisms of the body, especially in an inexperienced user or somebody who's getting a higher dose than they expected, or sometimes it's used for suicide. And again, so it is deadly potentially. And yet it can also be used medically, like so many other things. If I give somebody too high a dose of a blood pressure medicine or a diabetes medicine, that can also kill them, right? So again, the dose is the poison. Heroin, in fact, by a different name, the medical name is actually diamorphine, and it's widely used in a number of countries and hospitals and other clinical settings for pain control, even in children. So again, when used carefully, it can be beneficial, just as it can also be harmful. Why am I interested in this particular topic? You may wonder. Before I forget, I should say that I do have a few handouts here for those of you that are interested. I have a limited number of handouts for those of you that want a hard copy. I also have a copy of my sources. Now, there's a mysterious brown liquid on some of the sheets. It's not heroin, and in fact, I was actually puzzled by where this mysterious brown liquid came from, and then realized that I had left my windows open a crack last night, unfortunately, and so there was some water on my seat when I put the copies of the report there, so sorry about that. There was some addiction issues in my family. My father was, had problems with excess alcohol use and nicotine. But also, I was very influenced when I was in college. I guess it was my second year in college, and a friend handed me a book. Unfortunately, it's out of print now, but it's just a fascinating, well-written book by the editors of Consumer Reports magazine, and it's called Licit and Illicit Drugs. You can still find it if you're curious. And it was chapter by chapter an accounting of the science and policy side of different drugs. So there was a heroin chapter, and a nicotine chapter, and cocaine chapter, and that sort of thing. And what was stunning about the book was that it presented, as I will today, I think, for those of you less familiar with this, it presented some surprising information about heroin. In the mind's eye, the public eye, the image of a, quote, heroin addict, unquote, is often somebody who is running around, maybe committing crimes, in poor health, often gaunt, and has a lot of psychological issues and that kind of stuff. And yet that is not something that is an inherent quality of the heroin. That really has more to do with the policies surrounding heroin. So what drug users look like and whatnot is often a function of the context in which they exist. And so if you find people using the same substances in different contexts, you'll see very different outcomes. I am not, by the way, an advocate of drug use, so I just think we need to use science and sort of a harm reduction approach when looking at what kind of policies are we going to have on drugs. I also have a preventive medicine and public health background. I studied at the graduate level in preventive medicine and public health. And within the public health and preventive medicine community, there's different approaches to these things, of course, but public health tends to adopt a harm reduction approach to things. That's an approach that's more common in Europe and some other countries than it is here, although I think it's gaining some currency here. And that is to say that in some cases where you've got something like alcohol use, marijuana use, certain forms of drug use, rather than hoping that the problem will just go away and we can scold people enough that they'll stop using, instead we may want to look at actual models that have been tried in different places and look at certain outcomes. For example, not just how many users are there, but also, let's say, for example, in the case of injected drugs like heroin, how many new infections are there? How many overdose deaths are there? There are various different outcomes that you can agree are important, and then make a determination of when we adopt this policy, what happens, when we adopt this policy, what happens, and you can just compare them. And historically, what has often happened, especially in the US and some other countries, is as soon as somebody starts talking about a harm reduction approach, whoever's the loudest person in the room just starts yelling, well, that's crazy, especially politicians. As a politician, you'll never lose a vote by being hardcore on drugs and hardcore on crime and that kind of stuff. And so frequently the discussion never really gets started. And regardless of where you stand on some of these things, to say that we shouldn't even have a discussion, I think, is a bit much. And it's not very scientific. So, and then of course, as a physician, my patients have addiction issues, they have pain issues, which often require medicines that are potentially addicting, and so that's why I'm interested in this topic. How many of you have always wanted to be in an experiment, by the way? Okay, so have any of you had the brownies that are on the... I just happen to have made some brownies. Actually, they don't have any drugs in them. Unfortunately, they'll be less popular, I suppose. But, so anyway, okay. Actually, we're piping it in through the vents anyway. Okay, I thought I would talk for just one slide about America's Prohibition Era, 1920 to 1933, because it has a lot in common with, it has a shared history with the ongoing prohibition against other drugs. Alcohol, of course, is just a drug. It's a drug that, for the most part, in U.S. history, has been legal. There were a bunch of people elected to Congress in 1918, I think it was, that were from the so-called dry camp, and then there were the minority were in the so-called wet camp, the ones opposing prohibition. There was a very brief partial prohibition on alcohol in 1918 that had to do with war efforts and reducing the amount of grain that was used and that kind of stuff. And then the real prohibition came into effect in 1920, although it was vetoed by Woodrow Wilson, who had a large supply of alcohol. But nevertheless, the Congress overrode his veto and the alcohol prohibition was imposed. It did not forbid the use of alcohol, interestingly. It forbid the manufacture and transport and so on and so forth of alcohol. And so if you had the means, you could still make your own wine on your own property and consume it up to 200 gallons a year. And so, as with so many policies, it was really a prohibition aimed mostly at the poor, and it was aimed at the so-called lower classes. There was a lot of racism involved in it. In fact, at one point, the KKK was one of the biggest backers of the prohibition. It was very much a rural versus urban thing, really fascinating. And then toward the tail end of the prohibition against drugs was imposed, and a narcotics bureau was formed. And that was headed by this guy. If you're interested in this topic, you will want to know this name, Harry Anslinger. I sometimes think of him as Harry Gunslinger. He was an unfortunate person. He was, I suppose everyone's a worthy human being. I'm an Oasian after all. But this guy, who was regarded as more or less incorruptible and honest, but he was, of course, a true believer. And sometimes when you get a true believer in a position of power, it can be a disaster. And he was very hardcore, especially about marijuana. He was hardcore about heroin also, but he was especially hardcore against marijuana, as you'll see shortly. And he was a cop his whole adult life, basically. And he, before he was, for a while, he was an assistant commissioner in the Prohibition Department itself. And then when that was disbanded, he became the first commissioner of the U.S. narcotics force, and that lasted, and he was in that position from 1930 to 1962, and so he had a huge influence on attitudes in the U.S. toward drug policy and whether we should have a police approach or a prisons approach or a harm reduction approach. He also traveled widely around the world and influenced a lot of other countries to go the same way. In fact, the idea of using, finger wagging and prisons and police is referred to frequently overseas as the American model. So here's an example of some of his brilliance. For some reason he was particularly bad about jazz. Because jazz, of course there were a lot of black musicians that did jazz and that sort of thing. He basically hounded many of them. Many people feel that he hounded Billie Holiday to her death or suicide, and he prevented her from working in clubs, because he had influence over whether the club had an alcohol license or not. And so any club that she was going to sing in, he would not allow them to have alcohol if they were going to let her sing there. So she wasn't able to sing, basically. So he went after a whole bunch of jazz musicians, and he thought that, it's so funny because he thought that he recognized that the opiate or opioid medicines, opioid refers to when you make a synthetic version that is either taken from or analogous to morphine. That's an opioid, that's synthetic. An opiate would be something that's derived from the plant itself, from the poppy plant, the opium poppy. Here's a reassuring quote from the incoming Philippine president. So this is an example of the people, and this is not characteristic of everybody who favors a police and prisons approach, but anyway, this guy makes Donald Trump look, this is the new one, he makes Donald Trump look mild. All of you who are into drugs, you sons of bitches, I will really kill you, I have no patience, I have no middle ground, either you kill me or I will kill you idiots. So, but I started to say earlier, I have a tendency to wander, as you'll notice, and it's not the drugs. It's not the drugs. Anslinger was more hardcore about marijuana, which he saw as having zero redeeming properties, whereas he recognized that there were some medical applications for opium or opiates. Excuse me. So, what is addiction itself and physical dependence? Some people make no distinction. I'm not sure the distinction is hugely important, but addiction is sometimes regarded as the behaviors accompanying, needing a particular drug. And physical dependence has to do with a description of the physical consequences of needing a particular drug, and in particular of exhibiting withdrawal symptoms when you don't have the drug. But addiction is curious because it seems to be context dependent, and I'll explain what I mean by that in a minute. American soldiers in Vietnam, opium was widely available. It was an unpleasant place to be. and a lot of them didn't want to be there to begin with, and so there was a huge amount, some people estimate 50% of American soldiers using opium or heroin while they were over there. And so there were predictions, given what we knew about opium and heroin and opiates and addiction, that when they came back to the States, there was going to be this massive heroin and opium addiction. Now, whether you use opium or heroin, again, has to do with policies and historical context in the country that you're in and that kind of thing. Heroin, of course, is basically a concentrated analog to opium or to morphine, which is extracted from the plant. And so if you're in a place where you can readily get opium, you may be an opium user if you're inclined to that. On the other hand, if you're in a place where it's heavily restricted, you're more likely to use heroin because it's far more concentrated and it's obviously easier to smuggle and use a very small quantity of something to get the same effect than to have to transport and use larger quantities of something. But when American soldiers came back after Vietnam, and they went back to their communities and to their usual context and so on and so forth, it was uncommon for them to be addicted to heroin or to use heroin. They just stopped. That was what happened to the vast majority. And so lab rats, they used to have an experiment which appeared to describe what happens with lab rats that are given either heroin or cocaine. And you can see this see this described in an excellent video, which I highly recommend you watch. It's mentioned in the resources here, and that's a TED Talk by Johann Hari, H-A-R-I, called "Everything You Think You Know About Addiction Is Wrong." Highly recommended. And it talks about what they did originally with the experiments showing how addictive these substances are. Is they had lab rats that were just sitting in a cage by themselves, and they had access to either water or water laced with heroin, or water and water laced with cocaine. Those were their two choices. And sure enough, after a while, they would, use the laced water in favor of the regular water, and that was shown as proof of how highly addictive these substances were. Somebody came along a number of years later, fortunately, and said, well, that doesn't really look like a natural world setting. Let's put them into a cage where they have normal socializing, they have access to food and companionship and so on and so forth, and wheels that they can run around on and so on and so forth. And then they were given the same choice of water or water laced with a drug. And they rarely used the water laced with the drug. It was just a completely different outcome based on the experiment being done in a different way. And it seems that that connection is critical to the whole addiction concept. In other words, there are experiments, for example, with people who have suddenly lost a loved one, whether from being jilted or what have you, and when they describe the physical reactions they get, they're often identical to withdrawal symptoms from a drug. And that shouldn't surprise us so much because it's the same circuits up here that are involved, right? Endorphins, what are called endogenous opiates, or the opiates, the opiate-like molecules that are in our own brain. Heroin itself, I'm going to run out of time, I think. How much time do I have, Mike?
Well, you're going to allow some time for Q&A too, so let's do another 10 minutes.
Okay. So heroin itself was first made by a chemist named Wright in 1874. He basically took morphine and added a couple of chemical groups to it, but he didn't really do much with it after that, but it was in the literature. And then maybe 10 to 15 years later, Bayer Corporation chemists came along, and they took the same molecule and found a way of making it in industrial quantities, which was the advance they made, and then they marketed it as heroin, because they wanted to make it sound heroic, basically. And it was a cough medicine, because there was a fair amount of tuberculosis at the time in Europe, and it is effective as a cough medicine, in fact. All opioids or opiates are effective cough suppressants. In fact, if you use too much, you'll suppress the cough permanently. Heroin, like I say, is basically modified morphine, And the benefit of modifying morphine chemically is that it makes it more concentrated, number one, and fat soluble, number two, which means that it has different properties when it goes into the body. Heroin, again, by the medical name of diamorphine, is commonly used, especially in the UK, where it's used in a variety of settings, including severe pain, even pain after surgery. And instead of over here where we think, oh my God, heroin, over there is just another one of the medicines that's, called by its medical name, not by its Bayer Corporation brand name. And it's just, it's described as one of the medicines that you can use, and here's how you use it safely, and here's how you use it appropriately. So it's roughly 3 times stronger than heroin. It can be injected and swallowed and smoked and used as a suppository and a whole bunch of other things. It's popular because it causes rapid onset, intense euphoria. You can see why that would be attractive. First-time users, tolerance develops quickly. Tolerance meaning you have to use more of it to get the same effect. Tolerance develops quickly. As an initial user, you might use 5 to 20 milligrams. As an experienced user, you'll need several hundred milligrams. Roughly an estimated 0.2% of the US population is currently using heroin. And again, using and addiction are not the same thing. There are plenty of people with virtually every drug who use it but are not addicted to it. In Portugal, at one point, up until about 2001, it was an estimated 1% of the population that was addicted to heroin. We talked about this a little bit. Heroin, by the way, is not the strongest opioid. Fentanyl is the strongest opioid that I know of. Heroin's roughly 3 times stronger than morphine. Fentanyl is 100 times stronger than morphine. I have prescribed fentanyl. Now, I don't do it on a regular basis. I used to work in a pain clinic, but more recently, I had a patient that came in and was seeking to be established with a primary care doctor. She had cancer all over her body, basically. She was in severe pain, and she was on fentanyl already, but she had inadequate pain control, and her cancer doctor had already told her a month earlier, you need to increase the dose of your fentanyl. Because again, all these drugs, even fentanyl, which is far stronger than heroin, there's a safe way to use it. It's like anything else, right? The dose is the poison. If you use it carefully, then you shouldn't have a problem. And so before increasing the dose of her fentanyl, I decided to go back to the books and see what the latest information was about the safest way to escalate the dose in somebody who needs it. And what is, for virtually any medicine you look at, there is a recommended upper limit or a maximum daily dose that can be described for that medicine. So at least I know what my ceiling is. And I was startled, in some ways startled, although it made sense in light of other science, that it said right in the latest information for prescribing a fentanyl that there is no known upper dose limit. In other words, used appropriately, going back to that dose is the poison concept, used appropriately, you can use, and that's why heroin addicts can use huge amounts of heroin, and many of them get away with it because they're experienced. So, again, it's used widely in the UK. In fact, recently I saw a study in which it was a safety study specifically looking at the use of diamorphine, which is the medical name for heroin, and they use it after major trauma, and they use it in children even. And this was a safety study that looked at over 200 patients, including children as young as 2 years old, and the upshot of the study was that they saw no significant safety consequences of using that medication. Cocaine, by the way, is also used widely in medicine, mostly by ENT doctors and eye doctors, because it's a great topical anesthetic. It's in the same family as lidocaine, novocaine, things like that. They're probably not going to tell you that they're using cocaine on you. Unregulated use or so-called recreational use of heroin is problematic because people share needles. It's a scarce commodity after all. You don't want to be seen using this stuff. and there's risk of HIV transmission, hepatitis B, hepatitis C, both of which can cause liver cancer. I treat a lot of hepatitis B and an increasing number of hepatitis C patients. And of course, the risk of respiratory depression. There's a huge amount of data in the medical literature on the long-term consequences of heroin use. The best data I know of comes from 2 government clinics, or government hospitals basically, that were open in the 1930s for a few years. And they were the narcotics farms. They were actually called the U.S. narcotics farms. I'm not sure how they got this through while Anslinger was still head of the narcotics department. I'm sure he wasn't happy about it. But if you were a heroin addict, you would register as a heroin addict, and you might be able to get into this narcotics farm, which was self-sustaining. The residents actually farmed the place. And then they decided to use it as a study also. In fact, addiction science largely started in these hospitals. And they followed these residents who were often given high-dose clean heroin daily, followed them for years, mental and physical studies, adequate nutrition, adequate housing, that kind of thing, and they really didn't find any significant health consequences of long-term high-dose heroin use in hundreds or thousands of residents. Again, that's counterintuitive, but this is what the science shows. Again, if you rush right out and use heroin right now, you're going to have respiratory depression and die. So I'm talking about supervised use in a clinical setting. We talked about that. A lot of people, of course, doctors these days are getting blamed for causing the current rise in heroin use. The current rise in heroin use is occurring in very localized areas. It's occurring mostly in middle-aged white males. Wait a minute, why are you looking at me? Mostly people who have been disemployed, for example, people whose worlds are changing and they're not quite sure what to do about it. Lower educated people. So the Cochrane Review is one of the most hardcore evidence-based reviews that you can do in medicine for anything. And when they looked at whether pain patients are becoming addicted, they found that the number was tiny, in fact. Let's see, we talked about that. Drug policies in different countries all winded up. Basically in the US, there's long been, largely because of Anslinger, this very punitive approach. It's regarded by nearly everybody, even proponents of the punitive approach think that the drug war has been a failure, increasingly. In Portugal, there's a few places in the U.S. where they're starting to experiment with a different approach. The Hawaii House of Representatives recently voted unanimously to at least begin the discussion of decriminalizing all drugs. It hasn't been ratified by the Senate. Obama now is talking about, let's at least get the discussion out in the open. Again, regardless of what your view is, at least let's discuss it openly. Portugal has one of the most fascinating public policy experiments. 2001, they had a heroin epidemic. And they kept tightening the screws, more prisons, more police, that sort of thing. And it got worse and worse and worse. They got together a blue ribbon panel of all these experts from all sides, looked at all the evidence, and decided to decriminalize all drugs. Actually, partly legalize, because if you're carrying less than a 10 days supply, and they have various different definitions for that, then that's basically legal. If you're carrying more than 10 days, then that's considered an offense, but it's a misdemeanor, and you're taken to an administrative court where you're treated nicely. You're treated like, and they're basically at the community level. So these may be people that you know, and they find out what their problems are. They're not treated like the scum of the earth. They're not treated like people who have failed. They're given treatment. They're offered treatment for depression or for the addiction itself. They may be given job skills training or whatever it is that they need. They're spending a lot less on police and prisons, and there's controversy about whether usage rates, because a lot of people say, oh well, drug use is going to skyrocket. Well, that hasn't happened. Drug use hasn't necessarily dropped either, but when you look at things like I was saying before about overdose deaths, and infection rates from HIV and various other public health measures, those have plummeted dramatically in the face of more openness, where if somebody now has a problem, they can discuss it openly. Otherwise, they're afraid to go to the doctor and afraid to get care frequently. Other countries are doing similar things, let's see. I went to a conference recently in Washington, D.C. It was a hepatitis conference, and I was in a large room filled with people, many of whom were past IV drug users, many of them infected by HIV or hepatitis B or hepatitis C or all three, all from having used drugs. And they were advocating for policies that make it easier for people to get hepatitis C treatment and hepatitis B treatment, that sort of thing. And it was really fascinating because many of them were involved in harm reduction programs. Clean needle exchange, for example. Clean needle exchange like they have in Austin, Texas. It's not legal in Austin, but the police look the other way, basically, fortunately. And you know, when you have a clean needle exchange program, you're not increasing the number of needles in the community. You're just making sure that they're clean needles. And the use of naloxone, you may have heard about that. That's a tremendous drug that virtually immediately reverses the impact of an overdose. So again, if people can openly seek care and that kind of thing, then families and friends can be, you know, and naloxone can be made available so that you have fewer overdose deaths. In Switzerland, for example, where you go to a clinic and a doctor or a nurse administers your heroin, if you're an addict, they've had 0 overdose deaths in the last 3 years. In Sweden, where they're much more hardcore about it, although they have less heroin use, they also have triple the rate of overdose deaths of any other country in Europe. And I guess that's about it. So I'll stop for questions and comments.
Thank you. Our first question is going to be over here.
Dr. Andrews, fascinating. I'd like to ask, my hometown where I'm from is suffering from a heroin addiction problem. It's an inundating the criminal system, and as long as I've been involved in the legal system back home, we were, as lawyers, always given educational material about addiction and problems if you worked in the field. And at that time, the big talk was about opioids being prescribed or overprescribed for common injuries such as back injuries. These may have been blue-collar workers who were injured on the job and who then fall into the prescription pill problem. And then when that problem manifests itself into I've lost my job and I don't have any money, they start going to street drugs. And the most common street drug that they've been using is heroin, and that has created a whole nother problem. Do you have any information or can you comment about that?
Yes, actually one of the slides referred to that. You remember when I referred to the Cochrane Review? Increasingly, you'll be happy to hear, increasingly medicine is looking at actual outcomes and seeing which things actually work from a scientific perspective. Believe it or not, that didn't used to be common in medicine. And fortunately, over the last couple decades, it is now becoming the standard, where you can't just say, I'm a bigwig, look at what I do, here's the right way to treat something. People are going to ask you, where's the evidence? So the Cochrane Review is considered the gold standard. It's basically a process for how you go about determining whether there's evidence for something. And when the Cochrane Review looked at the question of how many patients that are pain patients go on to be addicted to their opioids, it was about 1% or less. So, I prescribe opioid medicines to patients that have pain. Frequently, for example, when you look at the guidelines, and the CDC just came out with new guidelines that make it a little bit stricter, but when you look at guidelines for what to do when somebody has pain, you're told to use, and I agree with many of these guidelines, by the way, and I try to follow this approach myself. You start with non-pharmacologic methods. Non-pharmacologic meaning not using drugs, right? So first you say stuff like, well, you're only sleeping 5 hours a night, why don't you try getting 7 or 8 hours a night, and maybe your back pain will be better. Work on things like weight loss and physical therapy. There's a whole variety of non-pharmacological things, even things like yoga, tai chi, acupuncture. We have an acupuncture person at my clinic also. And I'm an enthusiastic proponent of all that stuff. And for some people that works. Now, once you've gotten rid of the people for whom that works, then now you're left with the people for whom that wasn't so beneficial. And of course, many people can't afford physical therapy. Physical therapy, I'm a huge believer in physical therapy, but it's also expensive. And if you don't have insurance, or if your insurance is lousy, or you can just barely afford the premiums, and then you're surprised when you find out what the word deductible actually means, you see. And so for a lot of my patients, these things simply aren't available, or they're working 2 and 3 jobs. I work in a clinic for low-income patients, and a lot of my patients don't, they don't have access to yoga or popping down to the gym for a little workout, stuff like that. They're having trouble accessing those things. Then they talk about using what are called, non-opioid pain medicines. But there's a very limited supply of these. I mean, there's a whole bunch of different names, don't get me wrong. Typically, the most common ones used are things like Tylenol, which I prescribe all the time, non-steroidal anti-inflammatory medications, the so-called NSAID medications, which includes ibuprofen, naproxen, which is another word for Aleve, and things like that, Motrin. So all these medicines are in the same class, which is non-steroidal anti-inflammatory medications. I prescribe them all the time. My mother took them at one point, extremely effective for certain conditions, and so when it's appropriate. Now, they cause bleeding from the stomach, for example. So if I know my patient has had a previous bleeding ulcer, I'm not going to prescribe it to that patient. That's what's called contraindicated. And so if the patient doesn't have contraindications, that is to say a reason why I shouldn't use the medicine, then I will use it in that medicine. But then you're left with another group of medicines for whom that wasn't either appropriate or effective. And then you have to start looking at the opioid medications. And even the guidelines say there's a group of patients for whom opioid medications are appropriate. And again, when used appropriately, they're extremely effective and extremely safe. So there's a lot of myths out there that simply aren't true, and I think we should adopt a harm reduction approach rather than telling people who have pain, you shouldn't be given the medicine that works best for you because somebody else is having an issue with it.
Okay, so we basically have time for one question.
Sorry.
Are you going to be at lunch today?
Yeah, I'll be at lunch, yeah.
Okay, so Richard's going to be at lunch. If you'd like, I'm sure a lot of you have questions. If you'd like to chit-chat with him, you can probably stick around a few minutes after here. We've got to clear out of here. But you can visit with him over lunch at the Corner Bakery, 9630 West Timer. Okay.
Okay. How is DMT different from heroin and other controlled substances like that? And is it possible to use drugs safely in a legal setting? I've always been afraid because I think it's unhealthy or they're unhealthy. Is it possible to use them in a safe manner? For fun?
Yeah, recreationally, yeah. So, DMT, I've heard of it, but I really don't know a lot about it, so I can't really comment about that. I think there certainly is a way to use virtually any drug safely, and one of the benefits of having harm reduction policies in place is that you can do health education to everybody, including people who are at risk of getting addicted or at risk of having other problems. When everything is kept in the closet, as it were, then it's really hard to educate people, especially people who haven't started using yet. So remember, the dose is the poison. So there's a safe way to use everything, including the fentanyl I talked about, which is probably 30 times stronger than heroin. And even this, there's a safe way to use it. So thank you very much.